Hello, welcome to our INFORMS presentation. The setting for our study is the state of West Bengal in India. We'll be examining the public health system in that state that's run by the government and focusing on two particular performance challenges that they have been facing for the last decade or so. And we were introduced to these challenges in a series of discussions that we had with senior officials from the Department of Health and Family Welfare of the government of West Bengal. Our research team consists of Biju Paul Abraham, Rahul Roy, and Priya Sitaraman from the Indian Institute of Management, Calcutta, and I am Amit Datta from George Mason University. So the state of West Bengal has 33 districts, and in an effort to balance access to healthcare with quality of care and still keep costs manageable, the public health system is arranged as a three-level system. At the lowest level, you have primary healthcare centers, PHCs. There are about 900 of them, of these medical outfits that are spread across the state. The next level, there are about 60 of them. These are subdivisional or district medical centers. And then at the highest level, there are tertiary care centers. These are usually super specialty or specialized medical entities, outfits, and there are 13 of them, and they're usually located in major urban centers. Now, this three-level healthcare delivery system, the public health system, exists within a larger ecosystem. So here is your three-level public health system. And I'll just point out a couple of major aspects of the larger ecosystem within which it operates. First of all, there is a prevalence of private hospitals, an increasing number of private hospitals and private practitioners who are also delivering healthcare. Now, in the past, it was government that did most of the healthcare delivery. It still does, but increasingly private hospitals are playing a more significant role. Then, of course, another major part of the ecosystem is the medical colleges and nursing colleges that are producing the human capital to run this public healthcare system. And then, of course, there's the government itself, which provides both the resources to run the public health system, as well as sets the rules of the game in terms of how it operates. So that's the general ecosystem within which the public health system, the three-layered system, operates. Now, coming to the two performance challenges that I mentioned, the first performance challenge is one of disparity in utilization. So between the lowest level in that three-level system, the primary health care level and the tertiary care level, there is a huge disparity in utilization. You can see from the chart on the left-hand side, these two bars, this one and this one, that just documents for you the disparity in utilization levels. Low levels of utilization, of course, not desirable given the large capital outlays for these things. High levels of utilization may seem good on the surface, but oftentimes they manifest themselves as long waiting times and a degradation in quality of care. So in any case, the disparity of utilization levels is of concern. It's a challenge. And the second challenge that this public health system is facing is shown on the right-hand side. If you look at the yellow line, it has an oscillatory behavior, but there is a very clear upward trend. And what that represents is that the proportion of patients from the primary level, from the lowest level, who are being referred to higher levels, that has been steadily increasing over time. Now, we expect a certain percentage of patients at the lowest level to be referred up the chain because PHCs are not designed to handle all kinds of illnesses, complexities, and so forth. But what is of concern is that that proportion is increasing over time, and that has some implications of possible overcrowding at higher levels and underutilization at lower levels. So these two challenges the public health system is facing, and our intent is to try and find out what are the underlying mechanisms that might be resulting in this kind of behavior. Now, since we are looking at a temporal phenomenon, a phenomenon that's evolving over time, and since we're interested in getting at the underlying mechanics with an eye towards crafting possible interventions to address these challenges, we have decided to use the system dynamics methodology to model the environment from which to try and extract the underlying mechanics. So the diagram that you see before you is a first step This is the causal loop diagram. Now it shows the network of cause-effect relationships that drives the referral of patients from the primary level to the tertiary level. So you see the primary level here, you see the tertiary level here. So this diagram captures the network of cause-effect relationships that drives the referral from the primary level to higher levels. Okay, now this basic structure has been derived from extensive conversations with various specialties, specialists and officials who work as part of this public health system, and an analysis of the narratives of those interviews. So it's data driven, based on interviews from the field. This structure that you're seeing. Now, this structure can be parsed into a few components, which are quite revealing in and of themselves. One component that you can that exists in that other structure, in that structure that you just saw a minute ago, what that component, it's a reinforcing loop. So it's a positive feedback loop. What it is saying is, the more patients that go through the primary level, the better for the doctors and the physicians, the human capital at that level, because they get more exposed to different kinds of diseases, they get more expertise in terms of treating patients, treating illnesses, and so forth. So the human capabilities increase, and that's a good thing. So the more patients that go through the primary level, the better the capabilities of that level. But the flip side of that is over here, captured in this other subcomponent. What that is saying is, if you get more and more patients going to the primary level, the lowest level, it puts a greater strain on the physical facilities at that level, be it beds, be it instruments of various kinds, supplies. So a greater pressure on those resources means that the system reaches certain constraints, can't handle that many patients. It's not good for that level. Now, when you combine those two pressures, you get this particular structure, and the interplay between the positive and the sort of the balancing loops is what triggers referrals to higher levels up the chain. And referrals up the chain, as in terms of the effect on the tertiary care level, it's similar in one respect, that the more patients that the tertiary care level gets, the better off their capability, also improve their physicians, their human capital, the therapeutics and diagnostic capabilities of that level improve. But there's a flip side also to this transfer. The more patients who refer to the tertiary care level, the image of the primary care level suffers. Patients tend to get the impression that the primary level is not so good, they're not as capable, and hence they're transferring patients to the tertiary level, and new patients are would be less likely to come to the primary level over time as this image takes hold. So you have these different components that we have parsed out from the overall structure. This was the overall structure. Now, when you put those components back, and we want to see their collective effects, so in order to do that, we translated that overall structure, the causal loop diagram, into the next step and built this stock flow model, and we are going to simulate it. This stock flow model, we can mention that since our interest is in examining patterns of behavior rather than absolute values, we want to see did a behavior increase or decrease, rather than was it 10 or was it 11. So a lot of these functional relationships that you're seeing have been normalized to range between 0 and 1. Our intent was to try and make sure as far as possible that the functional form of the relationships are accurate meaning reflect reasonably well what we heard from the field in terms of the narratives that we got from the experts who were part of the public health system. So when we simulate the stock flow model, our intent was the following. So we first wanted to start from a baseline level, meaning that we have the system in steady state, nothing is increasing or decreasing, patients are coming and going through the primary level steadily, being discharged steadily, and then we're going to shock the system and see how it behaves. Usually when you shock the system, its behavior tells you a lot about what the underlying mechanics are, so that's the basic idea behind the experimentation. So we are starting from the steady state level, and in the first experiment on this left hand side, we shock the system by suddenly increasing the number of patients coming into the primary level, the lowest level. So we give this pulse, and what we would expect is, okay, the system would be disturbed for a while, its performance would suffer for a little bit, but then things would settle down back to steady state, to equilibrium. But that is not what happened. What we are seeing is runaway behavior. You look at the blue line and you look at the yellow line. The blue line is the referrals from the primary level to the tertiary level. And the yellow line, this one, is the flow of patients through the primary level. You can see both are showing runaway behavior. That is, after a certain point, what keeps decreasing keeps on decreasing, what was increasing kept on increasing. You have this runaway behavior. So we told ourselves, okay, in addition to shocking the system with new patients, let's give some additional resources. We give a fixed amount of additional resources to the primary level and see if that mitigates things. So the outcome, you can see if you compare this right-hand chart with the left-hand chart, investing in primary level resources. These are physical resources, things like beds, supplies, and things like that. If you increase resources, then it does mitigate runaway behavior somewhat, but doesn't contain it altogether. So the runaway behavior still continues, but it somewhat delays the inevitable, so to speak. Okay. Now, the next simulation we did was, next what if analysis we did was quite revealing, in that what we said is, suppose we have the physicians and the human capital that's there at the PHC level. Suppose they were happy with their position, the incentives were such that they feel good about the place, and the bottom line is they're less inclined to transfer patients out to the tertiary care level, or to look at it another way, they try harder to keep patients at the primary level rather than look for reasons to send them out. If you take that mindset in the what if analysis, we find much more stable behavior here, okay, which is desirable. As a last simulation, what we said is, okay, let's give a shock to the system in terms of increasing the number of patients, but let's be even more generous in terms of the physical resources that we give to PHC. we will tie the physical resources to the number of patients. So as the number of patients increase, instead of giving a flat amount of resources, we will keep increasing resources proportional to the number of patients who arrive. But even then, the runaway behavior was not contained. So the upshot of this simulation, this what if experimentation, is that once performance degrades beyond a certain level, this runaway behavior ensues, and it's very difficult to contain it. Second, it's more effective to devote attention to improving the human capital, those capabilities, compared to physical resources. If you have a constraint, then the focus should be more on the human side. Now, so to conclude, what we learned from this experiment, or rather this investigation, is that once perception of the primary level of that service drops below a certain threshold, it's very difficult to recover performance. Incidentally, when we analyze qualitatively the causal loop diagram, this very well-known archetype in system dynamics called shifting the burden became very apparent. And what shifting the burden says is that if you pay attention to symptomatic solutions, it will only delay implementing the fundamental solution. So here the fundamental solution is to try and build up capabilities, human capital as well as physical resources at the primary care level. But this mechanism of making referrals gives a symptomatic solution. It's an escape hatch, so it only delays attending to the fundamental solution. So this qualitative insights were found to be very valuable by the senior officials we presented them to. And also, as a result of our analysis, the officials that we presented our results to, they introduced an internal program to monitor specific performance parameters at the primary care level. And hopefully over time, that will result in addressing these couple of challenges that they have been facing. Thank you very much.